We move now to the next presentation with Professor Brian Reiner from South Africa, who will give us his thoughts and share about his knowledge regarding hypertension and chronic kidney disease from Africa to Mauritius, how to close the gap. So still thinking about how can we use your experience and your expertise in order to improve the practice in this part of the world. Thanks, Brian.
Good morning. Thank you to the organizers, Atil, Ruben, and others for inviting here to this very important conference in Mauritius. It's a great pleasure to be here in this lovely island, and you're giving me quite a challenge here to go over a lot of things, and so it's just really an overview of my thoughts. This is my hospital, the Grooteskuur Hospital, and those of you who know Dutch, that means big barn, and that was where the granary was for all the sailors coming around the Cape, and that's why the Cape Colony was established. The first heart transplant was done in the theatre 51 years ago, just over there, and the patient lay here, Dr. Louis Washkansky lay there in the hospital here. So, closing the gap, Mauritius, South Africa. I think one of the really crucial issues, the late Professor Bongani Moyosi, who was a leader in cardiovascular medicine in Africa, tragically died this year, and he said the 10 best buys is hypertension. And this is really important to understand this, because we're really doing poorly in this area, and we can do so much. This is sub-Saharan Africa. It will surprise you, number one cause of death. 500,000 deaths and 10 million years off. The average prevalence is about 40% in sub-Saharan Africa, and it's causing a lot of death, and it's rising dramatically, and I'll show you data. And the importance of this is illustrated in the PURE study, which was done by Salim Yusuf, 150,000 people worldwide. Cardiovascular risk factors were highest in high-income countries and lowest in low-income countries. But treatment and prevention followed this pattern, highest here, lowest there. And this translates into massive. So if you're in a low-income country, like Zimbabwe, Bangladesh, you have the highest risks of heart failure, stroke, and cardiovascular disease compared with high incomes. So despite bad lifestyles, preventative strategies, particularly around control of blood pressure, are critically important. And this is what's happening worldwide in hypertension in Africa. This is 2000. You can see the prevalences. Look what's happened to Africa. Unfortunately, there's no dot here, and I can't see the color for Mauritius. But you can see we've gone right into the red zone, around about 40%. So undoubtedly, every patient should have their blood pressure measured. This is what's happened particularly in South Africa. 11% of adolescents now have high blood pressure. 11%. So we don't talk about young hypertensive anymore. This is essential hypertension largely. And every age group has risen. But more importantly, it's causing death in the economically productive era of life. That's really important. So people are being educated, come into society, and then die of the consequences of high blood pressure. How are we doing in South Africa for controlling hypertension? There's a 91% unmet need. Half the population is unscreened. Screened, undiagnosed. Diagnosed and treated. Treated and uncontrolled. Controlled 8.9%. How's Mauritius doing? And it's a very similar story. Prevalence is lower, 28.7%. 15.4% controlled. And hypertension is not difficult to control, by and large. It's not like diabetes. Diabetes is more complex to control HbA1c. And so we need to follow guidelines. It's really very important that we have guidelines to identify who's eligible, monitoring practice, provide awareness, effective diagnosis, follow-up, clarifying the roles of healthcare, reducing barriers, and of course if we have electronic records, it enables us to get big data. And this is illustrated by the managed healthcare in the study, Kaiser Permanente. So managed healthcare, and they took this seriously. It's taken seriously there. So they doubled the number of patients in their organization because of increased screening. Target blood pressure rose from 40 to 80%, in 2011, 87%. What they were doing was preventing physician inertia and patient inertia and ensuring that the guidelines were followed. And this is also illustrated even in poor situations. This is from the Aborigine population published by Wendy Hoy, where she went to the outback of Australia. And the Aborigines there have one of the highest incidence of chronic kidney disease in the world. The highest incidence. That was death rate from chronic kidney disease. She introduced blood pressure control and programs to control blood pressure. She halved the mortality in 2 years from chronic kidney. Halved the mortality. She stayed there 5 years. But there's the tragedy. When she leaves the area and implementation of policy goes back to inertia, you go back to the original. That is the indictment. And so we need to follow guidelines. We have guidelines in South Africa, practice guidelines. If you want to go to guidelines into this very complex guideline of 100 pages, you're welcome to. But really, you need some simple approaches. And Mauritius also has clinical practice guidelines. I'm not sure when they're published, but I think they need to be updated. And I'm not sure which guidelines now you're following, but these are the practice guidelines. But there are a lot of similarities. Things are very straightforward. There's few sticking points. The definition between the guidelines is identical. I don't know whether ACA got up this new definition of 130/80. It's just crazy for our countries. You make the unmet need 95%. Risk stratification is important, as you heard. Basic evaluation, assess target organ, your lifestyle, compelling indication, contraindications for hypertension. Target blood pressure is the same, except in Mauritius they have a target of 135/85. In South Africa it's uniform at 140/90, and we're unlikely to change that. But there are differences, and I think mainly because the Mauritian guideline has not been updated. On blood pressure measurement, this is critically important because this really defines it. If you don't do it properly, you don't risk stratify your patient properly. Initiation of therapy, step care versus combination, choice of antihypertensive, and treatment of resistant hypertension. Blood pressure measurement is critically important. Unfortunately, office blood pressure is the least accurate. One, because of methodology, poor measurement, white coating, and masking. Ambulatory is the most accurate. There are different norms, but it's impractical in low-income countries. But we need to move to this. Self-blood pressure monitoring is very good and enables the patient and the doctor can get a lot of readings in the home, avoiding white coating. But also may be impractical. But increasingly, this way of measuring blood pressure, as in the SPRINT study, automated office, where you use a reliable machine to assess blood pressure. You take up to 5 readings and mean the last 4. And this can evaluate treatment. You can't assess diagonalization, but you avoid the white coat effect by and large. And this, I'm sure, one of the reasons why SPRINT studies showed positive results. The first-line drugs in the Mauritius, there's a whole range of drugs, and a step care approach was used. So you start one drug, second drug, and then a third drug. But increasingly, I think everyone is in agreement now that these 3 drugs, CCB, especially amlodipine, either an ACE inhibitor or ARB, not both, or diuretic, either indapamide or chlorthalidone. But importantly, in the African population, although we don't have evidence, diuretic CCB must be considered part of the combination because of salt sensitivity. And there's a Creole study which has been recently completed in Africa, which has looked at the 3 combinations: diuretic, ACE inhibitors, CCB, and CCB was diuretic. In our view, CCB diuretic may be the optimal choice in African population because of salt sensitivity. And also, probably increasingly low-dose spironolactone should be used for resistant hypertension. But in Africa, we have data that amiloride may be preferable. Unfortunately, amiloride is not registered in many, many African countries. I'm not sure about Mauritius. And also, to get control, we need to move in higher risk patients to starting true drugs, preferably in single pill combinations of the 3 frontline drugs. This is increasingly shown to get patients to goal and avoid both patient and physician inertia. And this is shown in a study we involved in, where they took hypertensive, randomized them to a step care approach with amlodipine, adding eliskerin, which is a direct renin inhibitor, much like an ACE inhibitor, and then combination with hydrochlorothiazide, step care approach with adenosine, or 2 drugs to start with. Now, what was critically important about this study, not surprisingly, if you started initial therapy, you achieved blood pressure control to a greater degree in 16 weeks. And so that's really important because you can show in hypertensive population improved outcomes. This population, and this is in a trial situation, eventually started catching up, but never, and these are significantly different, never caught up. So failure to institute treatment timeously leads to resistance to treatment. There were less side effects in this group. Contrary to expectation, less side effects in the combination group. No increased risk of hypotension. And this is in a trial situation where mandated up-titration was happening. Can you imagine what's happening in the clinical situation? And single pills lead to improved compliance by 69%, by almost 50%. And this guideline you can put on a simple A4 with a competing contraindication indications on the back. But the problem in Africa is that African people, for the same levels of blood pressure, have very high levels of target organ damage, particularly the small vessel. We tend to combine atherosclerosis with small vessel disease. This affects the small vessels of the brain, kidney, eye, and the pressure effects on the heart are most important. You can see all over Africa, left ventricular hypertrophy, very, very high prevalence. Look at chronic kidney disease. Very, very high prevalence of chronic kidney disease. I don't have dot. Heart failure is very common in the population. And chronic kidney disease may be the presence of APOL1 genes in the sub-Saharan African population that protects them against trypanosomiasis but makes them very vulnerable to chronic kidney disease because change in the function of the podocyte. And it is the reason that HIV-associated nephropathy is exclusively an African disease. Now we know hypertension can cause chronic kidney disease slowly and progressively due to small vessel damage. But what we find in our population, and I'm not sure this is happening in Mauritius, we have a large number of patients with malignant hypertension, which gives fibrinoid necrosis in the kidney. The blood pressure is hugely elevated. They're often in renal and heart failure, and they have these grade 4 hypertensive changes. And very interestingly, as I was hearing the talk on diabetes, these are thin patients without obvious risk factors, and young, often in their 20s and 30s, with malignant hypertension presenting de novo. The other issue in Africa is the common problem of angioedema with ACE inhibitors, and up to 1% of the population. So if you're using ACE inhibitors in the African population, you must advise them that if they get swelling of the lip and tongue, they must actually discontinue the therapy immediately. Chronic kidney disease is a major killer in South Africa, and this is a look at various cardiovascular non-communicable diseases, and you see chronic kidney disease in black is very prevalent, particularly in our Asian population. We have a large Asian population in Durban because many people from Asia are brought to KwaZulu-Natal to work the sugarcane fields, very high, and that's probably due to diabetes. But you can see the African population very much more prone than the Caucasian population, 21%. So that's really, and ischemic heart disease you can see is very, very high in the Asian population. So it's an important cause, and it's a rising cause not clearly seen, but there's a rising cause of chronic kidney disease in our population. Very, very 67-point increased risk of death from chronic kidney disease in South Africa. And this is one of the issues, this is a study that looks at chronic kidney disease. Now, there's a huge issue deciding is the EGFR by CK-EPI and MDR accurate in South Africa, in our African population. Because remember that 25% correction upwards for African Americans. So if you apply the correction factor, the prevalence is overall 6.7%. It rises with age. But if you don't add the correction factor, it's 23.9%. And there's a lot of work to suggest that we should not be applying the correction factor in the African population. So this is, for health economics, this is a very, very important statistic to plan health facilities. And we faced with the fact this was posted in cats, we had 1.1% of nephrologists per million population in South Africa. This has improved to about 1.78. We've now got about 100 nephrologists. I sort of did a calculation in Mauritius, which I could see is about 8.3. So in Mauritius, you have more nephrologists than in South Africa. We have 55 million people now in South Africa. But what is happening, and is one of the tragedies of our country, is that if you're in the private sector, the treatment rate for chronic kidneys is 716.3, which is comparable to everywhere else in the world. Because you get treatment, you have health insurance. For our patients who do not have health insurance, it's a tenth, 72.6. That means that innumerable people are dying from lack of dialysis facilities. Now, I'm not sure what's happening in Mauritius. Does everyone get dialysis in Mauritius? And look at this. Dialysis facilities were 5 in 1994 in the private sector. It's now, this is not out of date, it's over 200. In our public sector, it's gone from 26 to 28. So our government is not paying attention. I apparently looked up, Googled 10 dialysis centers, but prevalence of renal replacement I could not find. What about CKD in Mauritius? You have done good surveys here. Albuminuria, 6.8% of the population, and impairment of less than 65.9%. And 36% of the Mauritian adults have either one, hypertension, albuminuria, or diabetes. So you are also, in this country, facing this significant problem of chronic kidney disease. And look at the prevalence of albuminuria. Again, as you age, albuminuria goes up. And look, more females than men. Not clearly reason why this is, why there's more prevalence of CKD in women. And if you look at the Mauritius, what's happening in Mauritius, there's chronic kidney disease as cause of death. Number 4, it's gone to number 3. So it is significant. And if you look at death and disability combined, diabetes, massive increase, chronic kidney disease, a 40% increase. So you're facing very, very similar problems in the face of chronic disease epidemics. And this is diabetes in South Africa. This was done when our population was 33 million, so it's a bit out of date. Prevalence of diabetes, 7.1%. Total cases, 1.8 million. Undiagnosed, 1.5. In Mauritius, the prevalence has risen steadily, but interestingly may be plateauing. And it's at about 20%. But note, 33% had HbA1c greater than 9. So they are at great risk of chronic kidney disease and other microvascular complications with that level of uncontrolled HbA1c. If you look in diabetes in South Africa, 37.9% on our programs are diabetic. But interestingly, you see the differential here. Private sector is 47.2%. public sector 11.2%. So what it's telling you, the vast majority of diabetics do not get renal replacement therapy and dialysis. And of course we know from American surveys the prevalence of chronic kidney disease and diabetes is about 40%. So there are massive financial challenges in our country and perhaps in your country to manage this epidemic of chronic kidney disease. The other huge difference between our countries in regard to kidney disease...
Just don't worry about the time.
Okay.
I'm the timekeeper, so I have all the rights. So
I've got 2 minutes. 9.3% of patients on dialysis programs are HIV positive in South Africa. And unfortunately, we have a terrible history in relation to HIV. Our President of Country and Minister of Health told us that HIV did not exist, and that we should be eating garlic and lemons, and this will take our problem away. Such that now, if you look at South Africa, there's 6.9 million cases of HIV positivity. In Mauritius, there's 8,200, and it's 0.68% of the population. It's 12.79% of our population. It's published from WHO. And if you look at the risk of chronic kidney disease from HIV, depending which equation you use, it can range from 3.2% to 7.6%. It's all over sub-Saharan Africa. And this is where the APOL1 gene is, and this is where trypanosomiasis is present. So this is linked. But what's really problematical, we have changed our policy in South Africa. Everyone is eligible for ARVs now. So we're going to have, now if you're HIV positive and you're diabetic, your prevalence of chronic kidney disease is just under 20%. If you're hypertensive, it's just over 25% compared with the baseline risk of chronic kidney disease. So there's a collision of these epidemics. As patients are coming onto ARVs and living longer, and some of the metabolic effects of the ARVs are predisposing them to diabetes, we have this massive intersection here, and this is causing almost trebling the risk of chronic kidney disease and cardiovascular disease as well. So just focusing on kidney disease. So in conclusion, this is the low-hanging fruit. We're suboptimally controlling. We need to take policies and we need to get physicians and patients to take this on board. Just simply putting two drugs, you get 70% of hypertensives at target in single pill. Suboptimal nephrologists, diabetes, maybe declining, it's stabilizing in Mauritius, CKD, major problems. Death from CKD, increasing. HIV, perhaps negligible. HIV is a massive problem in South Africa. And it's not just chronic kidney disease, it's liver disease, it's neurological disease, hematological disease, and others. So, what are the solutions? Are we going to be drastic and restrict salt and sugar in the population level? South Africa is considering this, or has done that. Lifestyle changes in individuals, heard a lot of this. We need to be opportunistically screening for these. In our country, it's not happening. We need to implement the protocols properly. We need to account and have audits of how our physicians are doing. In the UK, they improved hypertension control by auditing general practitioners. We need to have more access to renal replacement therapy and screening for HIV. And importantly, we need more nephrologists and diabetologists. Thank you very much for your attention.
Thank you for this nice presentation. Are there some questions from the floor, from the audience? Well, I had just a couple of comments and thoughts. So basically, how do you explain this discrepancy between the investment in the public sector and the private sector? It's really shocking. I mean, nothing has changed in the last year.
About 500 billion rand has left the country to Dubai from our country in corruption. So we are short of money due to corruption. That's the simple answer, and mismanagement of health facilities. So there's massive corruption that's entered the South African economy, and it's bleeding our public health services. And there's no money for investment. Chronic kidney is just one example of the underinvestment in public health. I don't want to say too much bad about my country, but we've had the levels of maybe 1 trillion South African rand that is involved, which is almost our entire GDP. So those are the issues, and it needs to change. We're trying to change it now.
And maybe a quick comment, because I'm not at all familiar with this the HIV issue. So what are the link and the reasons? So I know about the metabolic effect of the treatment, but what is the link basically between HIV and chronic kidney disease?
That is very complex, and I think the metabolic effect of HIV drugs is overstated. Many people have done studies, and if it is happened with the modern ARVs, there's minimal effect. And I think this is maybe due to complex effects on inflammation. That, as you know, there's a strong link between cardiovascular disease and inflammation. You've seen the studies where we've suppressed inflammation recently and lowered cardiovascular disease independent of blood pressure, cholesterol, and so on. So people are studying this in general. So nobody knows the exact reasons at the moment. So there's a lot of groups now putting a lot of effort into understanding the link. But inflammation is the major issue that has been looked at.
Yes, please. Si on peut donner le microphone.
Thank you for your good presentation. I'm talking about HIV and diabetes and high blood pressure. We know that some treatment induce high blood pressure. Some treatment of HIV, heart treatment, can induce high blood pressure and metabolic syndrome. So maybe it is the reason that's why we find a link between those. And HIV by itself can induce metabolic syndrome too.
We've done this in our population, and the studies we've published, there was no increase in blood pressure in our patients starting ARVs. So we took ARV-naive patients and then treated them for 6 months and showed no change on blood pressure on ambulatory blood pressure monitoring. The vast majority at the start of therapy were normotensive, but what we did show is they had no nocturnal dipping in blood pressure. So their overall blood pressure load was higher. So why they're not dipping at night, we don't have any understanding why that happened. It was a very surprise finding, because these patients were free of chronic kidney disease, they were free of diabetes at the time of initiation. So there are studies from Norway which have shown a rise in blood pressure on ARV treatment. But that may be linked maybe to weight changes in weight, because as you start ARV therapy, you gain weight, because most people are quite wasted at the time because of, you see, lipodystrophy may issue, but there's been a change in the ARV drugs, so we're using drugs we have much less effect on lipodystrophy. It may be a factor, but I think that if you look at those discrepancies, you're talking about this 3 or 4-fold increase. It's hard to understand just on the basis of a slight increased risk of diabetes and blood pressure.
Talking about the number of patients in South Africa getting a proper control of hypertension is about 9 or 10%. In Mauritius, it's about 15, probably 20%, but still, I think we could improve that. We don't have problems of medication or probably giving drugs to them because it's being supplied freely by the Ministry of Health for all the person. In South Africa, is it a problem of drugs not being given to patients or compliance? Because you rightly say it's a problem of
I think all of those factors, drugs are available in South Africa. We have the price of giving 3 drugs in South Africa in our public sector, 3 generic drugs, is about 30 South African rand. So it's not the price of drugs. They are freely available. The bottleneck is patient education and as you rightly say, patient adherence. But 2, there's no investment in our primary healthcare clinics. So as I've shown you, you know that there's been no expansion in dialysis facilities, there's been no major expansion in public health facilities, and our population has gone from 35 million to 55 million. So there's a huge bottleneck of patients accessing the services to get treatment for blood pressure. So these are the things we need to fix. And our attitude to blood pressure as physicians as well.
So could probably our chairman say what is high blood pressure control in, I don't know, in France, in Europe? Is it so low as 15%, 10%?
No,
I think it's a bit higher.
It's much better. You know, in the US data I've got my fingertips, it's nearly 70%. In the US currently it's approaching 70%.
It's too high, 70%.
But with the old definition.
But you've seen the blood pressure at the population levels declining in the US. And that data has been clearly shown in the past 5 to 10 years. The level of the population-based blood pressure is declining in the US. But in Europe, it varies which country you are from.
Yeah.
But it's much better, I can tell you. It's order of 30%.
Maybe Jean-Philippe, you want to comment about France?
It's around 50% in France.
50% control.
Yeah, at the level of 140, 90.
So you're taking it more seriously in France.
No, we drink red wine. So maybe I will just thanks again, Brian, for his nice talk. Thank you, Brian. Just quick words to summarize. So we have learned from Caroline about these issues regarding heart failure in her region, and I really appreciated the talk about these new phenotypes, a lot of questions about these diabetic lean patients, but also this emphasis about the fact that heart failure is still undertreated and underdiagnosed and underestimated, and there was a plea to improve the management of heart failure, and also a message of hope maybe with these new treatments and SGLT2 inhibitors maybe in the management of these heart failure patients. We have learned from our colleagues from India about the issue regarding the epidemiology of diabetes, and a huge emphasis on the epigenetic and the pressure of the environment in the genesis of this disease, and probably a key message which could be applied everywhere, which is lifestyle modification. I think you really emphasize that changing our lifestyle could be the first path to improve and reduce the epidemiology of this silent killer. And finally, Brian emphasized the need to manage hypertension maybe in a more aggressive way. I was really impressed by the numbers regarding these teens who are having hypertension, so this young population, and you're right, we always call them secondary cause of hypertension or hypertension in children, but I think due to the prevalence of obesity or sometimes specific parts in your countries, I think hypertension is just now part of their natural history. And you also shared with us the data about the management of chronic kidney disease, the bad prognosis, but also the difficulty to manage this issue in these patients, and especially with this outreach of HIV infection. So again, I would like on behalf of the speakers and of Ruben and our co-moderator to thank you for your attendance, being there early this morning, skipping your coffee, being very interactive, asking us questions. And I'll invite you to just have some rest and then join us back in a couple of minutes. Am I right? At 11:15 back in the room. Thank you again for your attendance.